It's Dr. Barone in a hotel in Miami, and I wanted to make this tape for you to finish up the bladder pathology. We started up the initial topics, but I need to finish it up. So let's do these last couple of topics. Okay, urachal anomalies. And by the way, this I should not be there. It's like a little typo here. Something let's release that I. Let's get rid of that. So urachal anomalies. Well, the urachus normally is supposed to connect the belly button, the umbilicus, all the way to the bladder dome. So here's the bladder where the urine is. And so now the urine should be able to drain through here to the belly button and into the umbilical cord. So that's the urachus. Now it's supposed to obliterate. It's supposed to go away, obliterate. So if it's still patent, this connection is still there to the belly button, that is called a patent urachus. Now when this baby's born, what's coming out of the belly button will be urine. Urine coming out of the belly button. So remember, urine, urachus. Urine, urachus, that's a patent urachus. Now remember, feces are coming out of the belly button. Meconium, we want to remember about a vitelline duct fistula. That's a connection to the ileum. So that's a little bit different. But again, we have two things coming out of the belly button here, feces, that vitelline duct fistula, urine, patent urachus. Now, what if it obliterates but leaves little rests? Well, over time, those can dilate and become cystic. So you can get these urachal cysts, or if it's still connected out here, you can have a urachal sinus. But for urachal cysts, it prevents one here and one here. If you have these cysts here, over time they'll dilate, and the mucosa will get irritated. So unfortunately, this can lead to glandular tumors like adenocarcinoma. So this is going to be an adenocarcinoma occurring at the top of the bladder dome. Now remember, the lining of the bladder is transitional. It's urothelium. So most bladder tumors are called urothelial cell carcinomas or transitional cell carcinomas. If you ever see a tumor at the bladder dome, the top of it, it's going to be adenocarcinoma. So I know for a fact that's something they're going to ask you. So most bladder tumors are going to be transitional cell, but if you see one at the dome, remember the term adenocarcinoma. For the rest of the urachal, a urachal remnant has turned malignant on you. Okay, that's bladder dome. All right, now let's move and talk more about the urinary bladder. Lots of interesting lesions here. Cystitis, inflammation of your cyst, of your bladder. Inflammation of your bladder. Now it could be acute, or it could be chronic inflammation. Now symptoms, if I irritate the bladder, it's going to contract. So you're going to get frequent urination, frequency. You're going to get pain during urination, dysuria, and suprapubic pain. These are classic features you're going to find anytime there's inflammation of the bladder. Now, what usually causes inflammation of the bladder? It's usually infectious. It's infectious, particularly in women, because women have shorter urethras, so bacteria can make their way into the bladder through the urethra because it's shorter. So when a woman gets a bacterial cystitis, it's usually enteric bacteria. It's usually E. coli. Number one cause for bladder infections, number one cause for pyelonephritis, because it'll make its way up eventually into the kidney. So you got to treat bladder infections before they extend up into the kidney. You get pyelonephritis. Now, other organisms that can do it is Proteus, Klebsiella, and Enterobacter. Now, remember we talked about Proteus. It's a urea-splitting organism. So this can get up into the kidney and cause stones. Do you remember the magnesium ammonium phosphate stones? Yeah, it can cause those struvite stones for Proteus. And again, it's more common in women because short urethra, more cystitis, and then it can get up to the kidney and get pyelonephritis and stones. All right, now viruses can also cause cystitis as well. One I want to point out is adenovirus. Now I know, adenovirus, you think of the lungs, I know. But adenovirus can also involve the bladder, and when it does, it can give you a hemorrhagic cystitis. So not only do you get the pain, but you're going to have some blood in the urine. Now, radiation can also damage the bladder and cause cystitis too. So why would I be radiating that area? Oh, because the cervix is nearby. I'm not radiating the bladder, I'm radiating the cervix for cervical cancer, and the bladder is just nearby. So unfortunately, when you do cervical cancer radiation, you can radiate the bladder and get cystitis. For men, it would be prostate. But prostate, remember, the bladder sits on the prostate. So if you have prostate cancer that's unresectable, I will radiate the prostate, and I'm going to hit a little bit of the bladder. So you get a little radiation cystitis there as well. Now, one more thing can cause cystitis, and those are drugs, especially cytotoxic and anti-tumor drugs. Now, the classic one for exams is the alkylating agent cyclophosphamide. This is notorious for giving you a hemorrhagic cystitis. Now, the reason for this is cyclophosphamide will be activated by your liver. It's not active yet. When I give you cyclophosphamide, the liver cytochrome P450 system is going to activate it. This is going to turn cyclophosphamide into the active metabolite. The active metabolite is called a nitrogen mustard. Nitrogen mustard. No, not the stuff you put on a hot dog. No, this is mustard gas, like for World War I. This is pretty toxic stuff. Well, this is going to irritate. This is going to cause it's going to damage cells. It's not going to irritate them. It's going to mutate and alkylate the DNA. This is called an alkylating agent. It puts an alkyl group on the DNA, causing cross-linking. Well, if I damage DNA, I'm going to kill cells. That's why it's a chemo drug. It kills cells. It kills the cells because it damages the DNA by alkylating DNA. Now, when it gets activated, there's a metabolite, and that metabolite will irritate the bladder and cause cystitis. This metabolite is called acrolein. Acrolein. So if you look in first aid, you'll say, oh, hemorrhagic cystitis. Yeah, but they don't always explain it. I hope they do. I gotta look into it again. But acrolein is the metabolite that is made by the liver. When you break down cyclophosphamide, it goes into the urine and it irritates the bladder. Acrolein, that's what causes the hemorrhagic cystitis. So to prevent this, because doctor, do no harm. I don't want to put somebody on a drug and watch them pee blood. That's not cool. So we're going to give Mesna. Always give Mesna whenever I have to give high-dose cyclophosphamide. Oops, kind of came off the page here. Move it over a little bit. There we go. Give Mesna. Mesna will bind the acrolein. It literally binds it and prevents the irritation of the bladder. So this is an easy thing to ask on USMLE exams. Anytime I give high-dose cyclophosphamide, give Mesna to bind the acrolein. Now, one more thing I want you to know about acrolein. Not only does it irritate the bladder and cause inflammation and hemorrhage and cystitis, but it also irritates the bladder, so long-term, you're at risk for bladder cancer. So this is one of the risk factors for transitional or urothelial cell carcinomas. So very important to know about acrolein. Anybody with cyclophosphamide in the past is at risk for bladder cancer. All right, now there's some special forms of cystitis, some really unique ones. Now the first one is called an interstitial cystitis, also known as chronic pelvic pain syndrome. Now think about that, chronic pain in my pelvis? This is very uncomfortable. This is not cool. So this is a persistent, painful form of chronic cystitis. It's much more common in females, although males can get it too. And what they're going to have is from time to time, they'll intermittent suprapubic pain, pain in the suprapubic area. They'll get frequency dysuria. They'll get pain during intercourse, dyspareunia. Ooh. And every once in a while they get hematuria. Well, John, this sounds like an infection. This sounds like infectious cystitis. Yeah. But you look for bugs and you can't find them. You can't find them. You check the urine. Cultures are negative. Ram stains are negative. You can't find any bug. So again, that's the key. It looks like a chronic infection, but you can't find any organisms. And when you put a scope in, you'll see the mucosa often has areas of fissures and an area of punctate hemorrhage. So clearly it's being irritated, but there's no bacteria we can find. Now, how is all this inflammation going to heal? Long term, you're going to get transmural fibrosis. All scars contract. So eventually you're going to wind up with a contracted bladder. That's not cool. When you have a contracted bladder, you have to pee every like 10 seconds. Not a good thing. So again, we really don't understand this disease. It's a chronic inflammatory condition. We just don't know why. It's like a mystery. It's a mystery condition. We don't really understand it. Now, the next one is also kind of interesting for exams because it's a buzzword. There's an easy buzzword. If you get the buzzword, you'll get it right. This is called malakoplakia. Now, plakia is a plaque. So you'll see these plaque-like lesions inside the bladder. Now, this is due to defects in phagocytosis, so the macrophages either have trouble eating or they have trouble digesting. It's kind of like indigestion of macrophages. Now, the reason for this is usually because of immunosuppression. So there's something wrong with your immune system. So either immunosuppression or maybe an autoimmune disease, your macrophages are just not working properly. They're like eating bacteria, but then you can't digest them. So it's like indigestion. So what happens to the bacteria? Well, they accumulate. The little broken down pieces accumulate, and they get calcified, and they become these bodies, these calcified bodies. So you'll see inside the macrophage, phagocytes that are gorged with undigested bacterial products. When they start to calcify and get large, and I can see them under a microscope, we give them a fancy name, Michaelis-Guttman body. As soon as you see that, Michaelis-Guttman, Malakoplakia. Michaelis-Guttman, Malakoplakia. Because these are basically calcified deposits in the phagosome. It's all these calcified dead bacterial products that they couldn't just break down, they couldn't get rid of it. So it calcifies, so it's basophilic, it's blue, it's calcium, it's layered, it's got lamellar appearance, and it's concretions. It's a mineralized concretion inside the macrophage. Now again, let me show it to you. Woman's going to come in with cystitis. We put in a scope and we see these plaques. We biopsy the plaque, and here's what we say. In the submucosa, we're going to see these macrophages. Now notice all the abundant pink junk in the cytoplasm. You saw the pink junk in the cytoplasm? These macrophages are just packed with junk. Just packed with it. Now, they start to calcify. It turns purple. These are calcifications. See, they're round. They're like little concretions, like little stones. This is the Michaelis-Guttman body. So basically, just macrophages that are having indigestion. So, Michaelis-Guttman, Malakoplakia. 1 second diagnosis, and again, look for an immune problem. Look for immunodeficiency, look for some sort of autoimmune problem. Their immune system's just not working right. They're not digesting. All right, now there's 2 more forms of special cystitis. This one's kind of interesting, polypoid cystitis. So inflammation that makes the mucosa become edematous and it raises like a polyp. So it's an inflammatory condition due to irritation, and you'll see marked submucosal edema. When you get edema, you get these broad, bulbous polypoid projections. So if here is the mucosa coming along, all of a sudden you'll see this swollen, bulbous projection, big old polyp-like lesion. Now, why do I care? Well, you care because bladder cancer is papillary. So this is going to mimic the significance of this condition. Is when I look in there and I see all these, I'm going to think it's a bladder tumor. But you biopsy it, it's mucosa that's inflamed. That's all. It's edematous, swollen mucosa. That's all. It's all it is. It's not cancer. Now, it's often associated with an indwelling catheter. Does that make sense? That makes sense. The catheter's coming in here. It keeps hitting this mucosa. Well, if it keeps hitting the mucosa, this area becomes edematous. It swells up. And you get this polypoid lesion. And the next day, it kind of moves the catheter moves over here and irritates this area for a while, and you get a polyp there. Now, again, the significance is it looks like papillary urothelial carcinoma, but it's benign. It's just inflamed, swollen mucosa. Now, how about this one? Von Bohn's next. Von Bohn, it sounds like it should be related to Dr. Doom. Fantastic Four, Von Doom. Here's my brother, Von Bohn. It sounds like it should be a comic book villain. Von Bohn's next. Another name for it is proliferative cystitis. So inflammation, but this proliferation of the urothelial lining. When it proliferates, it grows down. It grows downwards. So here's my epithelial layer. And then this area starts to proliferate and grows down. So you'll see these nests of normal mucosa down in the submucosa, lamina submucosa. So it's basically downward growth of urothelium into the lamina propria, and it's just these nests of benign appearing urothelium. Now this is the key word here, benign appearing epithelium. Because guess what bladder cancer is going to do? Bladder cancer is going to invade into the wall too. But bladder cancer, when you look at it under the microscope, you see nests of malignant appearing appearing urothelial cells. So that's a very important clue here. We're going to see nests, like collections of benign mucosa down here. Sometimes you'll see the connection with the mucosa. Sometimes you won't see the connection. There's a connection you can't see in this plane. These are called von Brunn's nests. That's just inflammation leading to proliferation. Now, it usually increases in frequency in age. So I see this in older people a lot more than younger people. And we see it very common in the trigon area. That's usually where we see it. Now, when it undergoes changes, when it gets metaplasia, it gets cool names. I thought von Brunn's nest was cool enough, but sometimes the epithelium will turn to cuboidal or columnar. Well, columnar is more like glands. So we'll call it cystitis glandularis when these nests start looking like columnar glands. So you start seeing columnar cells lining it. Looks like glands. Again, they look benign. They're just metaplastic, turn to glands. Now, what if it turns to goblet cells? Well, goblet cells are the intestines. So this is called intestinal metaplasia. Now, question. Do you think intestinal plasia of the esophagus goes to adenocarcinoma? Yeah. Does intestinal plasia of the stomach go to stomach adenocarcinoma? Yeah. Does intestinal plasia of von Brunn's nest go to adenocarcinoma of the bladder? Yeah. And does the intestinal plasia? It's not where it should be. It can go bad. So we have two things now. When I see a lot of intestinal plasia get adenocarcinoma, or if you see a mass in the bladder dome, that's a urachal remnant that turned to adenocarcinoma. Okay, so two adenocarcinomas you better know. Finally, what if the epithelium becomes flat and it's basically cystic? So the epithelium is really flat. So it looks like a giant cyst. Then we call it cystitis cystica. Cystic from Brunn's nest. They're cystic now. So again, we just give it fancy names when it undergoes different types of metaplasia. It's still benign. Benign appearing epithelium below the normal mucosa. It's in the lamina propria. That's von Brunn's. All right, now let's get to money. Bladder cancer is something you need to know. It's actually increasing in America. We need to know about it. Now, it's more males than females, and they tend to be older, 50s, 60s. Now, it's much more common in developed nations than in underdeveloped rural nations. And it's more common in city dwellers. Urban environments, much more than rural. Now, probably a big reason for males and developed in this is because the number one risk factor is smoking. Males smoke more than females, although female teenagers are trying to catch up. Right? Women are trying to catch up. Teenage females are picking up smoking at a high rate. But still, men are still more commonly smokers. So that explains why it's men, more in urban areas, in developed nations, although we're sending cigarettes to underdeveloped nations too. But cigarette smoking, major risk factor, because all the carcinogens are concentrated for excretion in the kidney. So, increased risk of kidney cancer. Goes into the urine, into the ureter, increased risk of ureter cancer. Gets stored in the bladder, increased risk of bladder cancer. So everywhere along the way can get cancer. Okay, so it's a big risk factor. Now that's number one by far. The other risk factors are kind of rare but testable. So if you're working in an occupation where you're working with dyes, aniline dyes, like beta-naphthalene, as a beta-bladder, beta-naphthalene leads to urothelial cell or transitional cell carcinoma because it irritates. So that's the dye industry, like dyeing shirts, dyeing rubbers, dye industry. Now, beta-naphthalene is also present in mothballs. So little Timmy's crawling in your grandma's closet, he can smell these mothballs and eat them. If he eats mothballs, he's eating beta-naphthalene. And it's poisonous to moths, and it's poisonous to your bladder too. Now, we mentioned cyclophosphamide. Remember the acrolein causes cystitis, but it can also irritate and cause cancer long term. Another drug is phenacetin. Phenacetin was never really caught on in America. It was mostly used in Europe. So I don't know why it's on US MOEs, but if you ever hear phenacetin, it's an analgesic, a pain relief medicine that was not really very popular in America, much more common in Europe. But if you abuse phenacetin over time, all those little byproducts irritate the bladder. What about irradiation? If I radiate the bladder because I'm trying to hit prostate cancer, well, obviously those can lead to dysplasia and cancer. And then one more, if you're swimming in the Nile River and other places in Africa too, you can get schistosoma. Now, hematobium, see it's got a B in it? That's the one that goes to the bladder. Manson eye, got an I in it. It goes to intestines and liver. So Manson eye goes to intestine, liver, gives you a fibrosis of your liver. But hematobium goes to your bladder, irritates it, and when it irritates it, you get squamous neoplasia. So this one leads to squamous cell carcinoma because of irritation. You get squamous neoplasia and then squamous cell carcinoma. Kind of rare, but if they're coming from Egypt, swimming in the Nile, think it's just the cell hematobium. All right, I want you to look at this picture. We put a scope into the bladder. Now, do you see this kind of polypoid little fingers here? Polypoid mass here, another polypoid mass. And you see little polyps in the bladder, polypoid masses raised. Well, it looks like some plaques here. This might be dysplasia here. So this is a polypoid tumor. That's what they look like. Now, transitional cells, the urothelium, lines everything from the renal pelvis, the ureters, the bladder, part of the urethra. So you can get these cancers anywhere from the renal pelvis to the urethra. The entire lining can get these same tumors. Now, obviously, the largest surface area is the bladder, right? The ureters, kind of small, not much surface area. They're long, but not much surface area. Renal pelvis is a little bigger, but bladder's got the most surface area. So they can occur anywhere, but most likely these tumors are going to occur in the bladder because of the most amount of surface, and all the urine is just sitting there, like day and night. So yeah, bladder's the most common site. Now, clinically, if I have a bladder cancer, most common presentation, painless hematuria. Now remember the differential. The differential painless hematuria is the largest differential medicine because it could be my kidney bleeding, could be my bladder, could be my urethra, could be my prostate, could be my ureter, could be anywhere along the way. So often we're going to have to either do cytology to look for malignant cells, or we're going to have to put a scope in the bladder to see these masses. Because painless hematuria is one of the most common presenting findings, and the differential is huge. Now, it can also cause obstruction, so you can wind up with urinary tract infection, and even polynephrititis. If it expresses the ureters, you can get polynephrititis. Now, the malignant cells will be shed, so you can detect them by doing urine cytology. So again, cytology and looking in with a scope over what's going to be required to pick this up. Now, prominent bladder cancer it's often multifocal, and it often recurs. Yeah, look, get 1 year, multifocal. And the reason for that is, which part of the bladder is the urine touching? All of it, as you walk around, swishing it, but all over it is, when you're standing up, it's mostly down, and it switches around. Then you lay down, now it goes on the back wall, you roll on your sides. The urine's touching everything. So we give this a term, we call this the field effect. The carcinogens in the urine are touching the entire area. The entire area. So therefore, everything is getting mutated. So therefore, you can get a tumor here, and then a few months later, you get a tumor over here, and a few months later, you get a tumor over there. So they often get multifocal, asynchronous. You get one now, you get one in 2 years, you get one in a year later. So unfortunately, once you have a bladder tumor, you have to watch the whole bladder forever because it's a field effect. That's what they mean by multifocal and recurrent. The whole field is damaged and involved. Now, the key for these tumors, though, is how deep does it invade? That's the key. So depth of invasion and staging are the most important factors, right? Staging is always important for tumors, but for this one, the depth of invasion determines treatment. Is it superficial? We're treating superficially. But once it invades the detrusor muscle, cystectomy time. Not a good thing. You don't want to live in that bladder. It's not cool. All right, now the types of bladder tumors, by far the most common, is the normal line of the bladder's transitional cell. So transitional cell carcinomas are the most common type. Now, when I was in med school, they called it transitional cell lining. Nowadays, they changed the name. They call it urothelial cell lining. All right, I'll play the game. The most common tumor is transitional cell carcinoma, but now we call it urothelial cell carcinoma. All right, I'll play the game. So urothelial carcinomas are the most common type by far. Now, if you're swimming in the Nile That's when we're going to start thinking about squamous. This is common in my Egyptian friends, and it's associated with schistosoma infections, which lead to inflammation and therefore metaplasia. So you get metaplasia to squamous, then you get invasive squamous cell with the keratin pearls, the keratin whorls, all that stuff that we see for squamous cell. Now, just for fun, I just want to list this right here. When you get squamous cell, it's usually people from Egypt. So they're swimming in the Nile. So what is the intermediate host of schistosoma? Well, it's the freshwater snail. It's Gary. It's the freshwater snail. That's who carries schistosoma. That is the intermediate host. So schistosoma is going to hang out in the snail. Then it gets released and it free swims. It swims by itself up to your leg, because you're standing there in the Nile, swimming in the Nile, there's your foot, funny looking foot. Now, what it does is it swims right up to you and it penetrates your skin. There's not many bugs that can get through intact skin. Most bugs need a cut to get in, not schistosoma. Schistosoma has enzymes that will digest the keratin and go right there, penetrate right through the epithelium. Now, once it gets into the bloodstream, where does it go to lay its eggs inside of you? Well, it depends. Hematobium goes to the bladder and lays the eggs in the bladder. Mancini goes to the intestine, liver, lays its eggs there. So if it lays in the liver, you're going to get pipes and fibrosis. You're really going to damage and get cirrhosis. Now, to remember that, there was a famous Egyptian singer. If you have any friends from Egypt, they will tell you. He was like Frank Sinatra of the Middle East. Frank Sinatra, he was a good-looking guy, he was in movies, he was a singer just like Frank Sinatra. Really great singer. Well, guess what? He grew up in Egypt. So as a kid, he's running around. He got schistosoma mancini. It went to his liver, laid eggs, and he got fibrosis of his liver. So what happened to him? He started vomiting up blood. The number one killer of cirrhosis is ruptured esophageal varices. He ruptured his esophageal valve and he bled to death. Bled to death. Number one killer of cirrhosis. Now, he was such an amazing singer that when they brought his body, they brought the casket through downtown, women were going to the top of the buildings. I can't live without it. And they would jump, as I went by, they would jump off the building. It'd be like if Justin Bieber died. I know you'd all go at the top of the IU, and I can't, I'm a believer. No, he's not worth it. But it'd be like something like that, like when Kurt Cobain died, it was cutting themselves. And, well, that's what happened. This guy was so amazing, such an amazing singer. Now, for hematobium doesn't go to the liver, it goes to your bladder and lays eggs there. Now, this inflammation leads to metaplasia. So now you're going to wind up with squamous cell. Squamous cell because of squamous metaplasia. So I want you to look like this. Are you ready? In ancient Egypt, I'm talking like hieroglyphics, ancient Egypt. Back in ancient Egypt, they thought men had periods too. Yeah. There's actually hieroglyphics of a guy peeing red. He's peeing red. Because in the old days, the men would be in the river trying to fish, get food for the family. They'd be throwing nets, they'd throw spears, they'd try to catch fish. Well, if they're all in the river, they're going to wind up with schistosoma. Yeah, when it gets to the bladder, it irritates them. Every once in a while, they go to urinate, and there's blood in the urine. The guy's like, "Ooh, blood in the urine. Must be my time of the month." But it's not fair, ladies. Guy gets a period, no cramps, no mood swings, no psychosis, just blood in the urine. It's not fair. Guy gets a period, that's a good one. They thought men had periods. That was the man's period. That's what they thought. Crazy, huh? So I want you to write this. Ready? What letter is this? S. S. S for schistosoma. S for swimming in the Nile. S for the intermediate host, snails. And finally, S for what kind of cancer? Squamous cell. Walk like an Egyptian, walk like an Egyptian. Got it? So it's kind of silly, but when you see somebody from Egypt on the exam, think schistosoma. And don't forget, eosinophils are needed to kill parasites. So in this body, you see inflammation with lots of eosinophils. Do you remember why? Because eosinophils have major basic protein. Major basic protein is toxic to parasites. So always remember this: must bust parasite, must bust parasite. Major basic protein, must bust the parasites. So kind of a silly way to remember eosinophils. You'll see them in parasites. That's what kills parasites. Now, here's a nice question. We're in Egypt, and we want to reduce the amount of bladder cancer that we're seeing. What could we do to decrease the amount of bladder cancer in Egypt? Control the snail population. Don't kill the snails, we need snails, but let's control their population. If there's less snails, there'll be less intermediate hosts for schistosoma. So I think that's a really good question, because it shows me you understand where schistosoma comes from. Very good. The intermediate host is the freshwater snail. All right, now that's kind of a rare tumor, but remember it. And then one more, adenocarcinoma, 2 times you gotta pick it. If there's a urachal remnant, so you have a tumor in the bladder dome, the top of the bladder, they got every day of the week. That's a tumor of the urachal remnant. Or you pick it if there's extensive intestinal metaplasia. Intestinal metaplasia is going to turn to glandular tumor, adenocarcinoma. So again, 3 major bladder cancers. By far, transitional urothelial cell is the most common. But from Egypt, you think squamous cell. And of course, you want the adenocarcinoma if there's a urachal remnant or intestinal metaplasia. By the way, this metaplasia can also occur when the bladder's open. Do you remember when we had extrophy? The bladder was open to the environment. What's going to get irritated? You're going to get intestinal metaplasia. You're going to get adenocarcinoma. That's another example of when you get intestinal metaplasia. All right, now genetics. There's a big difference between superficial tumors and the ones that invade deep. The ones that are superficial are usually initiated. They're caused by deletions of tumor suppressor genes on chromosome 9, particularly P16. Now, we've seen this one a couple times. P16, we see it with melanomas. We see it with a couple other tumors too. So P16 is an important minor break on the cell cycle. Now, another mutation that's often found superficial is mutations in fibroblast growth factor receptor number 3. Now, we're going to see this again later on when we talk about bone lesions. There's going to be a couple of bone lesions that have fibroblast growth factor. And then, of course, activating mutations in RAS. There's an protein. It's going to cause proliferation and growth. So for superficial tumors, P16, epidermal growth factor, and RAS. Now, what about really invasive tumors? Well, those are bad. They're invading. What are the bad genes we always think of? For really big, you want to think of that knockout of RB and P53. You knocked out the guardian of the genome. You knocked out the guardian of the cell cycle. Well, guess what? You're going to get very malignant tumors. Okay, so that should be easy to remember that. All right, now let's talk about precursors to invasion. So before we get invasive disease, we have non-invasive disease. We've got 2 things. We've got non-invasive papillary tumors, see the papillae, not invading anything. It's just growing upwards. And then we have flat urothelial carcinoma in situ. See, it's flat, hasn't invaded anything. It's just flat carcinoma in situ. Eventually, it becomes invasive. Invasive tumor. But I want to go back to some of the precursors. Before you get invasion, you can get papillary tumors. Now, these are called exophytic. Endophytic means going in to your mucosa. Exophytic means going up and out. So exophytic, papillary-like projections, that's classic. Now, there's a couple of forms. The most bland one is called the papilloma. It looks like normal mucosa just thrown up. Normal mucosa thrown up into little papillae forms. Looks totally normal. Then you start to see some low-grade dysplasia. We call this low-grade papillary urothelial carcinoma. Then you get high-grade dysplasia. We call it high-grade papillary carcinoma. But again, no invasion yet. No invasion. These are pre-invasive lesions. It's kind of like in situ, right? Now, another way it can occur is it can occur as flat lesions, like plaques. So papillary things are easy to say. Flat plaques are a little harder to say. This is called carcinoma in situ. Just thick plaques. So on gross, we'll see red, granular, thickened mucosa. So when I go back to this picture here, So these are the this tumor nodule, tumor papillae. But do you see these red areas here? These are probably high-grade carcinoma in situ. That's probably where it came from, carcinoma in situ. That's red granular plaques. All right, now under the microscope, it's not invasive, but the tumor cells look ugly. Yeah, you're gonna see malignant cells, they lack cohesiveness, they're not sticking together, they're just kind of discohesive, falling apart, and it's often multifocal. Again, field effect. Now the problem with the carcinoma in situ is if you don't treat it, the majority are going to progress to invasive cancer if you just leave them there. So you gotta treat these when we see them. Now eventually, both these lesions can become invasive. When they do, they invade the lamina propria, and eventually they can go into the muscularis propria. Oh, that's the key decision point. Before it goes into, if it's just here, the mucosa, submucosa, it's superficial treatment. Once it goes into this muscle layer, like this one, once it's in the muscle layer, now I have to do a cystectomy. Not cool, not cool. So again, you could have these invasive papillary ones, start out papillary, and now it's becoming invasive. We can just have the flat ones that just directly invade. The key is how far does it go in? All right, now let's take a look at some of these lesions. Here is the benign papilloma. Doesn't it look like normal urothelium? It just got papillary structures. You got this fibrovascular core. See the blood vessels in the middle? Fibrovascular core. So it's like a finger. We're cutting it on cross section. So we're seeing it on cross section. Let's cut through it. This is the fibrovascular core. On the surface is epithelium. Now, how many layers are you supposed to have? 5 to 6. Let me see. 1, 2, 3, 4. Normal number. Normal number of cells. Nuclei are small, but bland looking. Look, there's an umbrella cell layer. See the flat umbrella cell? So it kind of looks like normal mucosa cell. Normal appearing urothelium, just in a papillary projection. That's a papilloma. Okay, good. Now look at this one. This is called low-grade papillary urothelial carcinoma. What's the difference? Well, here's the central papillae, right here with the blood vessels and the fibrous core. That's the central. Now look at how many layers. That's more than 5 to 6. That's way too many. So this is why it's carcinoma. There's too many cells. Notice the nuclei is getting bigger than it was before. They're not very atypical, but they're bigger than they were before. And I want you to notice the mitosis. Where should mitosis be? In the basal. They should be down here. And the cells are supposed to proliferate from the basal, the stem cell layer. You see mitosis up there? That's abnormal. So again, this is a low-grade papillary urothelial carcinoma. Again, not invasive yet. It's a little papilla sticking up. Now, what about this one? Here again is the fibrovascular core. There's the core. Now again, look at the cell layers. It looks like there's more than 6 here. So there's increased number. But look at the nuclei. Compared to the small, bland ones, these are big, hyperchromatic, dark, ugly looking. Look at this one. This one, that's a tumor cell in Pittsburgh. Look at the size. Huge. So again, we're seeing nuclear variation, we'll see mitosis, and it's kind of discohesive. It's not sticking together. You got these spaces here. It's not sticking together as good as it should. So this is called high-grade papillary urothelial carcinoma because you're getting marked cytologic atypia. So too many layers plus very atypical cells. Now again, is the board going to ask you, here's a picture. Is it a papilloma? Is it low-grade? No. I'm showing you this because I want you to know, what does it mean, low grade? What does it mean, high grade? They're never going to ask you to grade it, but they'll ask you, what does it mean? If it's high grade, what does it mean? Well, low grade is better, high grade is worse. But again, as long as it's not invasive, local treatment. Local treatment for that, and that. All of them get local treatment. So telling them apart is not really that important. But I like to do it because I'm a pathologist. That's what we get off on. You, as a clinician, you don't care. It's papillary, it's non-invasive, okay, now I know what to do. Local therapy. If it's invasive into the muscle, all right, now I go to the cystectomy, get the surgeon in. So that's what you care about as a clinician. But I would be a terrible pathologist if I didn't get excited about this. All right, now let's take a look at the flat lesions. Here's the normal urothelium. Again, you should have 5 or 6 cells, 1, 2, 3, 4. And then on the top should be a flat umbrella cell. Beautiful, flat umbrella cells, flat cells on the surface. So this is what normal urothelium looks like. Now look at this. Much thicker, a lot more layers, And look at the nuclei. They're bigger than they are here. They're bigger and more typical. Notice the way the spaces around the cells, they're not sticking together. They're kind of discohesive. So this is called flat carcinoma in situ. Look, in situ, basic membrane, no invasion here. In situ, local therapy, all good. So we see enlarged pleomorphic nuclei. We see a loss of cohesiveness. And you're going to start seeing mitoses, again, above the basal layer. That's a mitosis there, the one I circled. It's above it should be down here. Mitosis should always be in the basal layer. But now you're seeing it up here, that's totally abnormal. So again, flat carcinoma in situ. Now, what it invades? Same treatment. The only difference is it when it invades into the muscle. That's when you change your therapy. All right, so we put it right here to make the diagnosis. Two things I want to do to see this tumor. I want to check the urine to look for abnormal atypical cells. And I want to do cystoscopy with biopsy. I want to look in, see those papilla lesions, biopsy them. Some plaques, biopsy them. I want to see what's there. Now, treatment. For superficial, non-muscle invading tumors. It could be invading, but not the muscle. So superficial, non-invasive tumors, local therapy. Local. So you could put a scope in and do a resection, grab all the visible things, pull them all out, get them all out. Number two, I can inject chemo into your bladder. We call it intravesicular, that's inside the bladder, intravesicular chemo. Just put the chemo in there, let it slosh around, kill everything. Cool. Now, that's not as sexy as this one. Topical immunotherapy. Get the immune system to kill it. Do you remember the BCG vaccine that people use to prevent TB in other countries? BCG? It's a bacilli-like TB, where we're going to inject it, BCG, into the bladder. Now, when I put these bacilli into the bladder, you're going to get granulomas all over the place. Now your immune system's activated, and those granulomas will destroy all the dysplastic, all the neoplastic stuff. It'll kill everything. Get your immune system. That's brilliant. Granulomas all over the place. So again, if it's local, we treat it locally. Resected, intravesicular chemo, intravesicular BCG. Now remember, we have to follow, because field effect. You often have recurrence, multifocal. You gotta keep watching. So we'll keep doing scoops, and we'll keep doing your insert cytology for the rest of your life, because you can always come back. Now the problem is if it invades the muscle. Once it invades the muscle, now you have to do a radical cystectomy. So that's done for three reasons, but the big one is tumor invasion of muscularis propria, the detrusor. So I made a big deal about localizing. I know what it's about. Now you also have to do it if there's carcinoma in situ or high-grade papillary cancers that do not respond to local therapy. If the BCG doesn't work, I can't resect. Well, then you have to resect the bladder if the local therapy fails. Now you're also going to have to do it, cystectomy, if the carcinoma in situ extends into the prostatic urethra and glands, because the chemo is not going to get into the prostate and glands. It's going to stay in the bladder. So unfortunately, if it goes into your prostate, we often have to do cystectomy too. So we want to see how far the tumor spreads. Now, if it's advanced in locally invasive disease or metastatic disease, now we're going to give systemic chemo, not just inside the bladder. We have to give systemic chemo for metastatic. Metastatic is hard to cure. So we really got to cure this before it spreads. Okay, third thing about bladder. Bladder tumor is very high yield, very testable. So let's do a quick review here. This is the bladder chapter review. I like doing these little summaries for you. Okay, now last time we talked about what is the most common cause of obstruction and hydronephrosis in infants and children. Well, do you remember where the pelvis and ureter meet? They often have a little obstruction there. So we call this ureter-pelvic junction obstruction. Now, this is important. Oh, by the way, this is also associated with a kidney disease. Do you remember multicystic dysplasia? multicystic, we see the cyst and the cartilage and all these like weird things. Well, that can often have this narrowing at this junction as well. All right, how about this one? What's the fibroproliferative inflammatory process that leads to high nephrosis? Fibrosis of the retroperitoneal. Oh yeah, retroperitoneal fibrosis. Remember, this is associated with the IgG4 related diseases. So they often get fibrosis of the mediastinum, they often get autoimmune pancreatitis, and they often get fibrosis of the thyroid gland too. Okay, associated diseases. Look for high IgG4. All right, how about this? Pouch-like evagination of bladder wall that increases the risk of urinary tract infections. Little outpouchings, a little diverticuli, you mean? Yep, bladder diverticuli. Urine just sits there like a culture plate. You can get UTIs. And again, that's often due to backup at high pressure, like BPH. BPH can't get out, pressure backs up. What is the most common cause of infectious cystitis? Well, for infectious cystitis, we want to think about colonic bacteria. So enterobacteria like E. coli is number one. Number one for bladder infection, number one for kidney infection. All right, now what drug was it that caused the hemorrhagic cystitis? Well, adenovirus can do it, but for drugs, I want you to remember cyclophosphamide because of acrolein. All right, what are you going to call when you have intermittent suprapubic pain, urinary frequency, dysuria, pain during intercourse, and hematuria without a bacterial infection? Because I was about to say infectious cystitis, but then there's, that is chronic pelvic pain, also known as interstitial cystitis. Not a very cool thing to live with, chronic pain in my pelvis. All right, one second diagnosis, McKellis-Guttman body. Oh, those counts up in the macular indigestion. Oh yeah, that's called malakoplakia. Malakoplakia, McKellis-Guttman. Malakoplakia, McKellis-Guttman. Very good. All right, how about broad bulbous projections of inflamed urothelium? Well, that's cystitis. But what kind of cystitis would you call it? If it's got polypoid, I'd call it polypoid cystitis. Again, it can look like papillary tumors, so we often, if we see it, we'll put it with the biopsy to see what it is. Just inflamed mucosal edematous. What do you call when you have downward growth of the urothelium into the lamina propria, but it's benign appearing? Well, that's called von Brunn's. Von Brunn's, that sounds evil, but no, it's just downward growth. And then you get all the cool metaplasias, right? You get all the cool type of metaplasia. Okay, what do you call it when you have a tumor of urachal rest at the dome of the bladder? That's called an adenocarcinoma. The rare times you'll see adenocarcinoma, bladder dome. All right, what are some risk factors for bladder transitional cell carcinoma? Well, risk factors is many, but the number one is smoking. Never smoking. Never beta-naphthalene. Never cyclophosphamide, phenacetin. And if you're from Egypt, never schistosoma and squamous cell. All right, what about the topical immune therapy used for superficial bladder cancer? Intravesicular BCG. Inject it, you'll make granulomas, and the inflammation will kill the tumor. Wow, that's so cool. Finally, what is the treatment for transitional carcinoma? Transitional cell invading the detrusor muscle? Cystectomy. Now, when I take out your bladder, I gotta make a new one using intestines. What a mess. I take a second intestine, I try to make a new bladder, test the ureters. It's really a mess. It's a mess. You like bladders are good. Bladders are very important. All right, gang, we're done with the meta section. I'll see you the next day. tape for you on the female genital tract. This will be the first tape in a series to try to get through this very important topic. Remember, in terms of genitalia, which is more important, males or females? Females by far. Females by far. There's so many more important lesions that boards can test you on. And females are special anyway. We love women. It's God's gift, right? So we gotta learn this chapter really, really well, because you're gonna see these lesions in people you know. So you're gonna have to know this. They're gonna ask you questions when you get with your relatives. So we need to know female pathology really well. So here's what we'll do. We'll start nice and easy. We'll start on the outside, and we'll work our way in. So let's start with the outside, which is called the vulva. Start there first. Now let's start with vulvitis, inflammation of the vulva. Makes sense? Inflammation of the vulva. Now what causes it? Well, a classic cause is irritation. So it's contact irritations, dermatitis, or contact with an allergen. So inflamed, red, oozing tissue, that's a dermatitis due to contact with an irritant or an allergen. Now notice both of them are erythematous, red, weeping, crusting, papules and plaques. So they look identical. These are all like crusting, red, oozing lesions. But basically, is it an irritant? In other words, is it urine? Like they get this urine incontinence and it's getting on the clothes and that's irritating the vulva? Or is it new soaps or detergents or deodorants? It's some sort of irritant. So whenever a woman comes in and says, "Doctor, it's red, irritated, I don't know what's going on," first thing you ask, are you using any new soaps, any new detergent, new laundry? You always want to go through the list of things that could be contact irritants. Now you also have to think about allergic reactions. It could be perfumes they're allergic to, or creams they try, or lotions. So there could be allergic reactions to some of the components of these things. So always look to see what they're doing that's new. Okay, because it's red, crusting, oozing, looks like contact dermatitis. Again, that's a type 4. Type 4 hypersensitivity, contact dermatitis, whether it's irritant or allergic. Now, it can also be infectious. Infectious can also cause inflammation. So a sexually transmitted disease like HPV, condyloma, herpes simplex, gonorrhea, any of the STDs can involve the vulva and obviously vagina as well. Now, let's look at an artist's rendition of the vulva. All right. Oh boy. All right, so here's the vulva area. Now, I don't know what this thing is. I have no idea what that thing is. I don't know what that is. But here's the opening of the vagina. This is the vestibule. Now, on either side of it, in the posterolateral, again, the anus will be back here. So this is the anterior view. This is the clitoris. That's what that is. I found it, the clitoris. Okay. There's the clitoris. Here's the opening of the vagina. The urethra will be right about here. The urethra will be right there. And then back here will be the anus. This will be in the peritoneal area back here. All right, now, there's opening near the vagina for the Bartholin glands. They're located, the Bartholin glands, like here and here, the posterolateral aspects. That's where the Bartholin glands are going to empty. Because remember, what do you need Bartholin glands for? Well, ladies and gentlemen, we really like these glands. They give us lubrication. Very important, right? So we like these glands. They're critical. Well, every once in a while they can get obstructed. You can get little blockages, so then these will dilate, and you get what's called Bartholin gland or Bartholin duct cysts. You get cysts. Now, unfortunately, these can wind up getting inflamed and becoming abscesses. If they become abscesses, we're actually going to have to cut them open and let them drain. We call it marsupialization. We cut it open, leave it open, so it's like a pouch, like a marsupial, like a pouch, like a kangaroo pouch. So we cut open and let it drain out. So not cool. We like these glands. We don't want them to get inflamed and abscesses. And again, this is often a complication of having inflammation of the vulva. It can lead to inflammation, narrowing of the opening, and now you get obstruction. So now you can get obstruction of the ducts. The Bartholin glands will dilate, become cystic masses. Now notice the location. So they're going to say the posterolateral aspect of the vaginal vestibule, the opening of the vagina. So lateral, posterior, just like I drew it. Now they often become painful when you become an abscess. They're painful. Painful large cysts, they'll have to cut into them and let them drain to the environment. That's marsupialization. All right, now this we've talked about already, a vasculitis of small vessels. It is called Behçet's disease. And there's a classic triad. I can't see, I can't pee, I can't eat spicy. Well, they can actually pee, right? But they do have general ulcers. They do have able to see, but they often have like uveitis or maybe conjunctivitis that can affect somewhat vision. But the mouth, they're gonna have these aphthous ulcers. So if they eat spicy, it burns. They can't eat spicy, it hurts. So again, it's kind of silly, but they can't see, which they actually can. It's just uveitis, conjunctivitis. They can't pee, but they can. They get ulcers, painful, and they get painful both. They can't eat spicy. Now, again, I bring this up in this chapter because we had a case of a young girl who came with genital ulcers. Now, when you see a young girl with genital ulcers, you know anything about it's herpes? In a young girl, you're going to say, hey, where's the uncle? Where's the dad? Who's sexually abusing this kid? You're going to start calling Child Protective Agency because you're thinking this is an STD, sexually transmitted. No, if you biopsy it, you'd see it's a vasculitis. But a lot of times they just think it's an STD until they start getting lesions in the mouth or start getting problem with the vision. When that occurs, the doctor will put it all together. They'll do a biopsy and they'll see it's a vasculitis called Behçet's. But again, I've seen a case where this was almost confused with child abuse. It's kind of scary for the parents because once they put a stigma on you saying child abuse, even if you're cleared, you walk just going like that's you're stigmatized. So again, be very careful as a doctor. We don't want to cast blame. We want to protect the children, but we don't want to cast blame until we're sure. Make sense? So see Child Protection Agency, let them sort it all out. But again, you don't want to kind of accuse people falsely. Very important not to do that. All right, now I've got to get the kids out of the room. Get the kids out of the room quick. All right, whoa, naughty pictures here. This is not cool. Look at this finger-like, little, wart-like lesion. This is nasty. Yep, these little lesions here, like warty. These are genital warts. This is condyloma acuminata. When they're big and elevated like this is condyloma. This is not good looking. Don't like this at all. Condyloma. Now, condyloma acuminata are genital warts. Another name is venereal warts. They're warty lesions that occur anywhere in the anal genital region. So they could be on the vulva, they could be in the vagina, they could be in the cervix, they could be in the anal region. If you're doing anal intercourse, it could be anywhere in this area. Now, it's most commonly due to HPV 611. I was remember 611 go to heaven because they give you a benign lesion. Nobody ever died from a wart. Now, it's going to kill your sex life, and for a guy, you might as well just shoot me, but it's not going to kill you. So 611 go to heaven because this is benign. It will ruin your sex life. Now, what are you going to see if you actually remove these? If you remove them under the microscope, you're going to see an HPV viral effect. Now, let me remind you, squamous cells should have lots of cytoplasm and very small round nuclei. That's what squamous cells should have. It should have lots of cytoplasm to be protected. Nice epithelium. Now, what happens when you have condyloma, viral infection with HPV? The nucleus tends to become small and crinkled. It's like a raisin, crinkled. And then around the nucleus, you see this clearing. The cytoplasm should be like pink. So it should be pink. And you see this clear space around the nucleus. That clear space, remember, this should all be pink. All cytoplasm pink. And then around the nucleus, you see this clear. That's called coilocytosis. A clearing around the nucleus. That's HPV. That's an HPV viral effect. So look for the term coilocytosis. If you ever see that, that's HPV. What is it described as? A perinuclear cytoplasmic clearing or vacuolization. It's usually around the wrinkled, raisinoid-like nuclear. The nucleus is all small and contoured like a raisin, really small. Now, in this picture here, It's kind of hard to see. I wish we were closer, but I think you can see most of the squamous cells have abundant pink cytoplasm until you get to this area. Notice the white halo around the nuclei. The little white clearing, that's the corticosteroid effect. And a lot of these cells have these white spaces. You see these white spaces? That's the corticosteroid effect. When you see that, that's due to HPV. That's HPV. By the way, look at the hyperkeratosis up here. There are a lot of keratin production because this is dysplastic. This is abnormal. All right, now good news is it's not going to turn malignant. These are benign lesions. It's the 16, 18, 31, 33. Those are the ones that lead to cancer. So this is called low risk of malignancy. Low risk HPV subtypes. Now, this can also be transmitted to neonates or newborns in a vaginal delivery. So as the baby comes through the birth canal, you can have the HPV on the cervix, on the vagina, and so as the baby comes through, it can be transmitted. Do you remember on the last exam, the baby swallowed and it was on the larynx? Yeah, these papillomatosis. So you see papillomatosis usually on the larynx and upper respiratory tract. Again, that newborn baby is not sexually active. So you see papillomatosis in a baby, they got it from the mom's birth canal. They swallowed some amniotic fluid, which had HPV in it. All right, papillomatosis, again, benign, but it's on their larynx. Now, how are we going to treat these nasty looking things? Because people are going to come in, first of all, they're very embarrassed. They're very sheepish, they don't want to come in. But eventually they come in because how are they going to, how are you going to get a new boyfriend and say, they'll be like, what never? Same thing for guys. We have something like this, you're like, who's going to date me, right? So it's very embarrassing. So please be sympathetic. And when they come in, we have several treatment options. We can put pedophlin on it. We could put TCA, this acid on it to try to break it down. We could try to stimulate your immune system. Now, for USMLE purposes, this is the one I would know because it's kind of cool. It's called imiquimod. It's kind of a weird name. But basically, it's modifying your immune system. It's activating your immune system. So wherever you put it, the immune system's activated, it comes in, it kills the HPV, and the wart will go away. By the way, we can also use it for melanomas that I can't resect. If it's already spread, I can't resect it, well, I can put this on an unresectable area, have the immune system come in, and try to kill it. Again, it's not really going to help any metastatic disease, but certainly will help with the local lesion. So that's kind of important, using the immune system to fight cancers. This is like the future. Now, another way you can get rid of them is you can laser them or cryotherapy, freeze them. Now, I thought it was interesting, because when I was at OBGYN, this guy was doing so many lasers. He was like making bank, just zapping these things. And I walked by the room and I was like, oh, the smell of burn, nasty. And then later on I read what happens to some of these doctors is when you're blasting these with laser, this goes in the air so you can inhale it and get HPV in your throat. I know. So these poor OBGYNs, some of them wound up getting HPV, and try explaining that to your wife. Honey, I got it from work. Imagine? Yeesh. So it went in the air. So you can laser them, just wear a mask, make sure you're covered. And then finally, we should be able to prevent some of these condylomas by doing the Gardasil HPV vaccine. Because this vaccine is going to cover the high-risk types, 16 to 18, but it also covers low-risk ones too. So getting the HPV vaccine can help prevent these things. Now, unfortunately, once you have them, the vaccine doesn't cure it, but it will prevent it. And I don't understand that. Why was it? It just doesn't, it prevents them. It doesn't cure them once you have them. Now, these are like finger-like projections, right? The big wart-like fingers. What do you call it? If the vulva has what looks like a condyloma, but it's kind of flat-topped. It's like flat, like a plateau. It's like a flat, it's not like fingers, like condyloma is like finger, ding. That's a condyloma you can out like fingers. If it's flat-topped, we call it condyloma lata. Now, this is associated with secondary form of syphilis, not primary, secondary. So whenever I see this flat top lesions, I want to get a VDRL because it's going to be positive. VDRL. That is our screening test to look for syphilis. And then you can confirm it with the fluorescent treponema antibody absorption test, which will also be positive. Okay, these are great tests. That's your screening test, VDRL. Confirmatory test is your fluorescent treponema antibody absorption test. Now, these are flat, moist, and minimally elevated. So they're basically flat top. They're like plateaus. What's it look like? All right, now, here's an interesting differential. Always learn your differential. Only comes in just a doctor. Can you check my private area? You look at the vulva, and you see a white plaque. Well, nobody pays you for white plaques. You gotta call it leukoplakia, a white plaque in the vulva. White patches, white plaques. So here's your differential. When you see these white plaques, I want to know, is it lichen sclerosis? That's going to be white because of fibrosis. Is it lichen simplex chronicus, which is thick skin, so it looks white? Is it intraepithelial neoplasia of the vulva, which is really dysplasia? They misnamed it. They call it neoplasia. It's dysplasia. So VIN and VIN, or is it vulvar squamous cell? Because both of these are going to be thick and white appearing. So whether it's dysplastic or carcinoma, it's going to be thick and white. Now tell me, which do I not want to miss? You don't want to miss dysplasia and cancer. Never miss cancer. So whenever I see a white plaque, what must be done? Biopsy. And by the way, same thing for your oral cavity. You see a white plaque, it's leukoplakia of the mouth. Biopsy. Because it could be benign, it could be malignant. Don't miss malignancy. So when you see white plaques, you biopsy. Now, what if I saw a red plaque? Well, then we change our differential. Red plaques is called erythroplakia. Erythroplakia. Now, that's a different differential. If I see that, you want to think about dermatitis. The contact dermatitis we just talked about, red, crusting, oozing, think about dermatitis, contact type. Now, the other thing you want to think of is, if it doesn't get better by avoiding contact, maybe some topical agent doesn't get better, you better biopsy it, because it can also be cancer. We call it Paget's disease of the vulva. Paget's disease. It's basically adenocarcinoma in the epithelium. We don't want to miss that. So let's repeat. In the oral cavity and vulva, if you see white plaques or red plaques, you should biopsy both of them, because they could be benign, but we don't want to miss cancers. So red things are probably Paget's if it's cancer. White things if they're cancer is going to be squamous cell of the vulva. Now, let me go through each of these in a slightly more detail, talk about what's important for exams. Again, all of these are going to present as white plaques in the private area. All right, now the first one here is lichen. Lichen. So lichen sclerosis. Now, with a name like sclerosis, what's making it white? Fibrosis. So here's the epidermis. Notice it's really thin. Really thin. It's very atrophic. But deep to that, look at all this pink fibrosis. Lots and lots of pink fibrosis here. So that's why from above it looks white, because of all this fibrosis. So these are smooth white plaques, and they often describe them, since the epidermis is very thin, paper-like, parchment-like, like parchment, like paper, because the epidermis is really thin. So remember the term parchment-like or paper-like white plaques? That's a clue for lichen sclerosis, because the epidermis is very thin. Now, it's most common in postmenopausal women, and it's probably autoimmune. It's probably autoimmune that leads to inflammation and fibrosis. Now, the reason we care about this particular lesion is a small percentage, 1 to 5%, will continue to squamous cell. That's if you can't miss a squamous cell. So if you see lichen sclerosis, we have to follow the patient, because they can develop squamous cell of the vulva. So we want to be on top of these patients and follow them. Make sense? Now, for the microscope, when we do a biopsy of it, we're going to see a very thin epidermis, very thin, and deep to it, we're going to see very thick dermal fibrosis, and there'll be a little bit of inflammation, because it is autoimmune, so a little bit of white, these little purple dots down here, a little inflammatory area, a little inflammation here, little purple dots. But again, it's just mostly fibrosis with a thin overlying epidermis. Now, the next lichen is called simplex chronicus. I just remember simply chronic scratching. If you chronically scratch down there, well, the epidermis is going to thicken to protect itself. So a better name for this is squamous cell hyperplasia. So look at this picture compared to this one. Look at how thick the epithelium is. This is why it's white, because the epidermis has thickened to protect itself from the scratching. It got really thick. Look at the thick granular layer, very thick granular layer from all the irritation. Lots of keratin on top, trying to get thick and protect itself. Now deep to that, you'll see a little inflammation from the irritation, but really it's about a thick epidermis. So squamous cell hyperplasia is a great name for this. So it's simply chronic scratching. That's it. Again, it looks like a white plaque, leukoplakia, and it's due to irritation for chronic scratching. Now good news, this is not going to turn malignant. But if there's a malignancy in that area, do you think you may scratch? Yeah, if you have like a bump there, you may scratch it and scratch it. So we often see this next to a malignancy. It does not lead to malignancy, but it's often next to it. So again, there's no increased risk of cancer, but it's often found next to cancers because we often get irritation and we scratch. Under microscope, thick epidermis. Thick epidermis, especially the granular layer. This granular, so there's little purple dots in there, purple granules. That's the stratum granulosa, the granular cell layer, very thick, characteristic of hyperplasia and scratching. You get hyperkeratosis, which is the pink stuff on the surface, the keratin. Notice no atypia and very little dermal inflammation. There's a little bit, but it's not a major component. It's thickening the epidermis. Now again, doesn't go to cancer. Close to cancer, but doesn't lead to it. All right, now let's talk about vulvar tumors. So what's the lining of your skin? Squamous. So what kind of cancer you gonna get? Squamous cell carcinoma, most likely squamous cell. Now there's actually two forms. The first type of squamous cell occurs in older women. It's usually triggered by lichen sclerosis. Remember we said 1 to 5% over time will turn to squamous cell? So that's one form. It occurs in older women. It's usually associated with the autoimmune phenomenon, lichen sclerosis. Now these tend to be very well differentiated. They make a lot of keratin pearls, a lot of keratin whorls, like good, well-differentiated squamous cells should. Now the other type of squamous cell is due to HPV. HPV, now this is less common, but it's associated with the high-risk HPVs, 16, 18, 31, 33. Why? Because these are the HPV serotypes that have viral oncogene E6 and E7. And this same thing I'm going to talk about now applies to any, like the cervix, the vagina, the vulva. When you have 16 and 18 there, they make viral oncogene E6, which is going to bind to and destroy your RB. I'm sorry, it binds to and destroys your P53, what am I talking about? P53. Destroys your P53. And then we got E7, which binds to and destroys RB. So very important we don't miss this. So it binds to, ubiquinizes, and destroys your P53, binds to, ubiquinizes, and destroys your RB. Well, if you're knocking out my major tumor suppressor genes, no wonder these are the ones that give me vulvar cancer and vaginal cancer and cervical cancer, because they got viral oncogenes, E6 and E7. And if I were to ask a board question, I want mechanism. So this is what I'm going to ask about. So learn it once, 16, 18, 31, 33, they're high risk of cancer because they have viral oncogene E6 and E7. E6 knocks out the guardian, the genome. E7 knocks out the governor of the cell cycle, the policeman, the roadblock, and you wind up getting proliferation cancer. All right, now in addition, the other risk factor for squamous cell of the cervix are things like smoking. Smoking is a risk factor. And of course, immunodeficiency, because I can't stop cancer. I can't stop the HPV, I just can't stop the cancer. All right, now precursor, before you get cancer that's invasive, you get dysplasia. What do we call dysplasia in the vulva? We call it vulvar intraepithelial neoplasia. Now again, it's misnamed. They should have called it dysplasia, they call it neoplasia. So remember the thing, VIN is the precursor for invasive cancer. Okay, now clinically, what does it look like when I have dysplasia or cancer? It's thick and white. So it's going to present as a white plaque. Classic. Or as it gets really big, it can present as an exophytic tumor, so a tumor that goes up. Or sometimes the tumor grows down. So you see this big old, deep, big old mass here? That's ulcerated on the top. So that's called endophytic, when it grows downwards, the tumor. Okay, so exophytic tumor growing up, endophytic when it grows down. Okay, so ulcerating tumor, polypoid tumor, or flat white plaque. Now, where's the most real estate in the vulva? The majora, labia majora. Now, wasn't that a Zelda game? Labia majora, Majora's Mask? No, I'm getting confused here. But labia majora, it's the biggest part. It's got the most surface area. That's where they're most common. Now, unfortunately, they can also occur in the minora, and they can also occur in the clitoris. No, can you imagine? Squamous cell carcinoma of the clitoris? This is terrible. Now, again, these women often do not come in. They're very embarrassed. Very embarrassed, so they often let them grow to huge sizes before they finally say, I can't take it anymore. And they finally come to you and they're so embarrassed. So please be respectful. Because I've seen a lot of doctors, they take one look and say, what the hell? What are you big? They start yelling at the patient. That's not going to help anybody. So let's be sensitive here, because this is important. This is a lot of who we are. So it's very, same to the guys. Guys don't come in until they get these giant penile tumors, and you're like, what are you thinking, dude? Just don't say it to their face. They're feeling bad enough already. You're gonna have to chop off part of their penis. Let's not limit it. All right, now, these tumors can remain local in the vulva for a long period before they spread. Unfortunately, these patients often wait a long time. If they wait up to catch it early, we can remove these and cure you. Wait a long time, they're going to spread. Now, the risk of metastasis depends on the size and how deep it goes. The deeper it goes, more likely is to find vessels. Now, here's something that I would ask. I always want to know where things go to. Where do they spread first? Because then once they spread, they go everywhere. Where do they go first? Well, it depends. If it's on your labia versus being on the clitoris. If it's on the labia, it's going to go to inguinal nodes, but the superficial ones. Or question, where it's on the clitoris? Well, that goes deep. Now I go to the deep inguinal nodes. So the clitoris has a different drainage, so it goes deeper. So I think that's kind of an important point. If you're going to be a clinician, you need to know where to look for metastasis. So clitoral tumors, look for deep inguinal nodes. Everything else, labia, any majora, minor, look at the inguinal superficial nodes. All right, now, red plaques. When I see red plaques, crusting, oozing, crusting red, I want to think dermatitis. But if it doesn't get better, avoiding all contacts and irritants and using some maybe steroid creams, if it doesn't get better, you better biopsy it. If dermatitis doesn't get better, you better biopsy it, because it could be extramammary patch disease. Now, the reason they call it extramammary because patch disease was described in the nipple. That's what was described, the nipple of the breast. So when it goes outside, they often call it extramammary, so you don't get confused with nipple, okay? Because that's where patch was described. Now, does this have anything to do with the bone disease, Paget's disease of bone? No. Dr. Paget described them both, but they're unrelated. So there's going to be a disease later on called Paget's disease of the bone that's unrelated to Paget's of the nipple and extramammary Paget's of the vulva. Now, here's the feature. Paget's is adenocarcinoma, but what's unique about it is it's spreading in the epidermis. Intraepidermal spread of malignant cells in the skin of the vulva. Now, if it's in the skin of the nipple, it's exactly the same. Adenocarcinoma in the epidermis. So let's repeat. Here's my epidermal layer. Epidermis. Here's my dermis. In the epidermis, you're going to see these tumor cells just growing along the epidermis. Now remember, they're not invading. This is never going to metastasize until it invades. The base of membrane's intact. Are there any blood vessels in the epidermis? Nope, all the blood vessels are down in the dermis. So until this thing invades, it's really an in situ tumor. You can totally cure it. It's in situ. Now, if it's in the nipple, it looks the same. But for the nipple, where did the tumor come from? Well, it's a breast tumor. It was in the duct, it grew up the duct onto your nipple skin. So it's in situ, but it grew up the duct. So when it's in the nipple, there's always a breast cancer that you have to find in the breast. So in the breast, you always have to look for an underlying tumor. In the vulva, there's no underlying tumor. So you just resect the area that's involved and you're done. You don't have to look for any other tumor, because most cases there's no underlying tumor. So John, where the heck did it come from? Well, do you remember you have little sweat glands? So the gland is down here, and then it comes up through the mucosa, and then puts the sweat onto the surface. Well, it's probably a tumor of these cells right here in the gland. So when they become malignant, they go into the epidermis, and they just keep growing across it. That's probably what it is. It's probably a sweat gland tumor. But the good news is, you just resect the area that's involved, that's red, remove it, and you cure it, because it hasn't invaded yet. It's only spreading in the epidermis, hasn't gone through basal membrane yet. Cool. Now the origin, we think most of them are coming from either the epidermis or usually from sweat glands. Probably sweat glands. It says a small number, but probably most cases of sweat glands, we just don't find it. All right, now for the microscope. The epidermis is infiltrated by large epithelial cells, which have abundant cytoplasm. They usually occur as single cells or small clusters, but here's the key, they're adenocarcinoma cells. So they're going to have mucus. That mucus is PAS positive. So that's very, very helpful. PAS positive, it's a great test to do. So you do PAS and these single cells will light up and you'll see exactly where they are. You'll see them. Now, this is important because another tumor that spreads across the epidermis, melanoma. Melanoma can spread across the epidermis too. They call it superficial spreading melanoma. It grows radially, horizontally across the skin. So these cells, you may think, wait, are these melanocytes? Well, melanocytes do not have PAS positivity. So very important to tell this under a microscope. Now in gross, it's easy. Melanoma is black. Paget's is red. It looks like inflamed red tissue. It's a red plaque. Melanoma is black. But under the microscope, it is confusing. So under the microscope, we get PAS positive. Remember, it resembles melanoma, but melanoma is PAS negative. What does melanoma have instead? It is positive for S100, and it's positive for HMB45. Human melanoma black. HMB45 positive. And I just remember this store. Do you remember H&M? Ladies, H&M? Imagine, it's Black Friday. Melanoma was black. Black Friday. 45% off H&M. 45% off H&M. Yeah. So that's a great remember. This is a very good marker for melanoma. So S1s are just good for melanoma, but that's for all neurocrest cells. All neurocrest cells are light up at S100, but HMB45, just melanoma. Good marker. Now, as I mentioned, clinically, Paget's looks red, scaling, crusting, oozing. It looks like dermatitis. Looks exactly like it. But the key is, it doesn't get better with avoiding contact, with cleaning, keeping your area clean, with using steroids. It doesn't get better. So it's not a dermatitis in the biopsy. Now, as long as it hasn't invaded, it's just combined to the epidermis, hasn't done the epidermis, you can cure. You can cure it. Now, if you don't cut it all out, it can recur. But if you get it all out, you cure it. Now, once it invades the dermis, now it can find a blood vessel and it can metastasize. Good news is, if you catch it early, usually you can cure this thing. That's good. That's good. Same thing in the breast. Now, for the breast, I can't just resect the nipple skin. I've got to find the tumor and resect the breast tumor with it. So that's a big difference. In the nipple, Paget nipple, I got to take the tumor out in the breast with the skin as well. Take it both out. All right, now here's what it looks like under the microscope. This is cool. It looks the same in the breast, by the way. Here is the epidermis. Epidermis is here. The dermis is down here. Now, I want you to notice these spaces. Do you see these spaces? Squamous cells are pink. Pink, 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 normal squamous cells. Do you see these spaces? That's the tumor cell, tumor cell, tumor cell, tumor cell. These are going to be droplets of mucus. That's what these clear things are. All the cytoplasm has a lot of mucus in it. So if you do a PAS stain, it's going to light up like the Christmas tree. Do you see all these tumor cells? Anything with a clear space, that's a tumor cell, tumor cell, tumor cell, tumor cell. And they're just percolating along. They're just growing along the skin. The skin will become inflamed, red. Look at the hyperkeratosis. You get crusting, flaking. And look at these old tumor cells. But notice basement membrane intact, 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 intact. Just follow around, no invasion, just remove this. Remove it and you're cured. Cool, love it. All right, now let's do some vulvar recall. Let's see if you remember all these vulvar lesions real quick. We just did it, so it should be easy. What was the cystic mass that can occur in the posterior lateral aspect of the vaginal vestibule? Can be painful, can get inflamed. Well, that's called a Bartholin gland cyst. And again, it can become an abscess. You'll have to drain it. Okay, what is the triad of I can't see, I can't pee, I can't eat spicy? That's a small vessel vasculitis called Behçet's disease. All right, vulvar leukoplakia with a thin epidermis and dermal fibrosis. That's called lichen sclerosis. Lichen sclerosis. And by the way, I'm such a geek. Every time I hear lichen, I think werewolf. Lichens, the lichens, werewolf, underworld. Have you seen Underworld? No? Oh man, I love vampires fighting werewolves. I mean, that's like geek fest. Oh, love it. All right, by the way, she's a vampire. She's a vampire that's a hunter. Selena, oof. I'll say no more. All right, now let's go back here and talk about vulvar leukoplakia. But it's got a thick epidermis with some dermal inflammation. Well, thick epidermis, that's called squamous neoplasia, or lichen simplex chronicus. Simply chronic scratching is leading to hyperplasia of the squamous cells. Okay, what's the vulvar lesion with choriocytosis? HPV. That's condyloma cuminata. That's an HPV effect. Condyloma cuminata. All right, what are these flat, moist, minimally elevated lesions on the vulva in a VDR positive patient? Syphilis. That's condyloma lata. Condyloma lata. Sounds like a new Starbucks drink. You want what? Grande condyloma latte? What? No, I don't want one of those. No, thank you. All right, now how about this one? Invasive nest of tumor cells with keratin pearls. Oh, in the vulva, invasive, that is invasive squamous cell. So that's invasive squamous cell of the vulva. That's the most common type of cancer you'll see in the vulva. All right, what's the precursor lesion for vulvar squamous cell carcinoma? Well, dysplasia, but they gave it a fancy name. They call it vulvar intraepithelial neoplasia, VIN. It's really dysplasia though, misnamed it. Okay, squamous cell of the labia, where's it going to spread? Well, that's going to go to superficial inguinal nodes. Now, if it's in the clitoral region, now it's going to go to deep. Think about deep inguinal nodes. So always inguinal, but it's superficial versus deep. All right, now what do you call intraepidermal tumor cells that are PAS positive mucin? Got PAS positive mucin? That's adenocarcinoma. That's called extramammary, so outside the breast, extramammary Paget's disease. And Paget's disease outside the nipple. All right, now what do you call intraepidermal tumor cells with HMB45 positivity? Well, that would be called a vulvar melanoma. And by the way, you do get vulvar melanomas, and I'm a little surprised. Whenever I get a biopsy, they say, I look, it's like melanoma, and it's like vulvar. I'm like, whoa. Melanoma's from the sun. I guess she likes skinny dipping. Vulvar melanoma. Wow, how much sun does the vulva get? Wow, interesting. All right, now let's go down on the vagina and really, listen, the vagina doesn't get many lesions. The vagina is very, very resistant. It's very tough. Yeah, what would they might say? Men, balls are not tough. How you eat the balls? You're alcohol. You need a vagina. Vagina, they take a pounding. Benny White said that. I was like, whoa, okay. So vagina very resistant to pathology. But when we do get pathology, it's always very interesting. Now let's start with the first one. Gardner's duct cyst. Now location, location. This is going to be located when you go into the vagina on the lateral wall. So location is the key. Cyst on the lateral walls. Now again, cyst at the opening, the vulva, well, cyst at the opening, that is going to be Bartholin gland. So let's just draw it here. Here's the vagina going in. Here's the cervix. Cervix. Okay, well, that's a very short vagina. Sorry, I should have made it a little bit longer. But anyway, so this is the vagina. Here's the cervix. If you have cyst here at the opening, that's going to be Bartholin gland cyst. What you're going to see in Gardner's duct cyst is in the lateral, the sides, the lateral walls. You're going to see cysts here in the inside, in the vagina, and the lateral walls. Now, what they usually ask is, why do you have that? Well, do you remember, in men, you have mesonephric ducts. In women, mesonephric ducts are supposed to undergo apoptosis. They're supposed to obliterate. They're supposed to go away. Well, what if a portion of the mesonephric duct sticks around? And then it kind of gets bigger and bigger. Then you have a Gardner's duct cyst. This is a remnant of the mesonephric, also known as Wolffian, right? Men are wolves. So for men, you're supposed to have Wolffian duct development. In women, it's supposed to go away. If the Wolffian duct doesn't go away, the remnant will become a cyst. That's the Gardner's duct cyst. And again, that's what they're going to ask you. They'll say the cyst in the lateral vagina wall, inside the vagina lateral wall. They'll ask, what is it? You're going to say it is a remnant of the Wolffian duct. Yeah, it's non-mucus secreting, it's just Wolffian duct remnants. That's it. Okay, now what about inflammation? Vaginitis, inflammation of the vagina. Well, this is often associated with a vaginal discharge. We call this leukorrhea. It's usually a white discharge coming out. So inflammation is going to be itchy, irritated with a white discharge. Now, this usually occurs because of infection. You get vaginitis because of infection. Now, the risk factor for getting vaginal infections, it's usually altering the flora. You're giving a growth advantage to some bug over another bug. So what's going to change the flora and allow some of the normal bugs to kind of take over? Well, diabetes. If you get diabetes, the high sugar can allow growth of certain bacteria over others. If you take antibiotics, this is a big one. A lot of women get yeast infections after they take an antibiotic because it changes, it knocks out the normal guys, and now yeast will take over. Immunodeficiency. You lose your immune system, you start getting infections. Pregnancy and recent abortions. These are all things that can allow bacteria or fungi to take over. Now, classic examples of this are trichomonas and candidiasis, two classic causes of inflammation. Okay, trichomonas vaginalis, notice 10% of normal asymptomatic women have it. So it can be part of normal flora. So when does it actually cause inflammation and irritation and vaginitis? Well, it only becomes symptomatic when either you have one of those predisposing factors like diabetes, immunosuppression, antibiotics, or you get infected with a new strain that's more aggressive than the strain you had already. And you get this from sex, sexually transmitted disease. So you have sex with somebody new, you get a new type, and that new one kind of takes over. Now, when you get this inflammation, you're going to see watery, copious, lots and lots of discharge, and it tends to be gray-green discharge. Now, if I look at the cervix, this often gives me petechial hemorrhages of the cervix. They call it a strawberry cervix. So this is a lot of clues. Copious, watery, gray-green discharge. You're looking at the cervix, you see a strawberry cervix. And then one more thing, if you look under the microscope, it's got motility. What kind of motility? Not tumbling, not falling leaf. It's got corkscrew motility. So remember, it's tricky to corkscrew a JJ that way, but if you do it right, you'll get a strawberry swirl of your cervix. I know it's kind of naughty, but that's the kind of stuff we remember. So remember the strawberry cervix appearance, the copious gray-green discharge, and the fact that they have motility. So it's corkscrew motility. That's how it moves, corkscrew. All right, now another famous one is candidiasis, a yeast infection. Now, Canada is part of the normal flora in about 5% of women. So when are you going to get an active symptomatic infection? Well, number one, if you alter the flora, you take antibiotics, all those risk factors we talked about before, or you get a new form, a more aggressive form of Candida, then that new strain will take over. So either you alter the flora or you get a new one. Now, this is going to be a lot different. Still itching, still irritated, but now you see this thick, white, curly batch of discharge. It's like this white, cheesy stuff going to the vagina. That's the yeast infection due to Candida, candidiasis. Now, under the microscope, you'll see yeast and pseudohyphae. Yeast and pseudohyphae. All right, by the way, I'm so naive. When I was in medical school, they'd always talk about candidiasis, right? And they'd say Candida vagina, Candida vagina, Candida mouth, Candida thrush, Candida vagina, Candida mouth. Like, damn, when I get older, I better go to Canada. Sounds like a great place. And my friend goes, no, you idiot. Candida, not Canada, the country. Oh man, that would have been such a mistake. I would have been off the plane and say, where's all the vagina? Oh, that would have been embarrassing. So, luckily he slapped me straight. All right, now the next concept we have to talk about are tumors. Again, pretty uncommon, but when they occur, very testable. So not a very common thing. Now, the vagina is squamous line, so we would expect squamous cell to be the most common type. But it's not that common. It's just not common. You just don't see a lot of tumors in the vagina. In fact, usually, if I see squamous cell vagina, it's not for the vagina. It's a cervical squamous cell growing down. So here's the key. You have to make sure the cervix is clear. If the cervix is involved, it's a cervical cancer. Much more common than squamous cell of the vagina. Make sense? So always check the cervix. If the cervix is clear, then it's a squamous cell of the vagina. Now, it tends to occur in older women, usually over age 60, and it's the same risk factors as cervical cancer. HPV, smoking, immunosuppression, same risk factors. Now, precursor, just like the cervix, you get dysplasia first. And in the cervix, we call it cervical intraepithelial neoplasia. That's what we call dysplasia. Do same thing here. Vaginal intraepithelial neoplasia. To abbreviate, we call it vein. Now, I don't want to give any jokes about the vagina being vein. That's what they call dysplasia. Dysplasia vagina, they call it vein. So, vulva, vein, vagina, vein, and then cervix, they call it sin. Ooh, you sinned. You did the nasty. You got HPV. They call it sin in the cervix. So again, it's really dysplasia, but they call it neoplasia. It's misnamed. Now, like I mentioned, most cases when you see squamous cell, it's really cervical squamous cell that is spread to the vagina. So you have to call it vaginal squamous cell, the cervix has to be clear. The cervix is involved in cervical cancer. Now, where does it spread? It depends. Which part of the vagina is it located, because the drainage is different. Now think about it. If it's in the upper vagina where the cervix is, it's inside. It's going to spread to inside your pelvis. It's going to go to pelvic lymph nodes. Now, it's the outer one, though, well, that's more outside. That's going to go to the inguinal lymph nodes. Inguinal. Make sense? So it really depends on where it is. The upper 2/3 are more inside. They're going to go to pelvis. The outer 2/3 are going to go to the inguinal nodes. All right, now, squamous cell is the most common, even though it's rare. But the board loves all the other ones. All these are the rare ones. Like clear cell adenocarcinoma of the vagina, it's very rare. I've seen a couple of cases, but it's very rare. So it's an adenocarcinoma with clear cytoplasm, clear cells, not many clear cell tumors. Now the reason they love it is the reason you get this is in utero. Your mother, she got pregnant with you. She wanted you. She was so happy. Oh, it's a girl. Oh, I want this girl to be healthy. Then she started bleeding. That is called a threatened abortion. She thought she was going to lose the baby. She comes to the doctor like, oh my God, you're bleeding? Let me give you an estrogen to maintain the pregnancy. So what they used to do up until the 70s, they used to give an estrogen called diethylstilbestrol, DES. Now the problem with this is, it didn't really maintain the pregnancy. What it did instead is it messed up in utero. It messed up the Mullerian duct system of the girl. It messes her up. So they gave the estrogen thinking it'll maintain the pregnancy. It wound up hurting the girl. So remind me, what comes from the mammary duct in a woman? Well, let's draw it here. Let's draw it. What comes from the mammary duct? Okay, we got the uterus here. Here's the uterine cavity, triangular. Here are the fallopian tubes. And here is your ovaries. Okay, what comes from the mammary ducts? Because that's what DES is going to mess up when this baby's in utero. You're exposing her to this DES. Okay, the upper vagina, upper one-third of the vagina, the cervix, the uterus, and the fallopian tube. So I'm going to outline. All of this comes from the mammary. In fact, do this. If you want to know what comes from the mammary ducts in a woman, warm up your hands and grab your ovary. Count 4 structures after that. So first thing comes off the ovary, fallopian tube. Second thing, uterus. Third thing, cervix. Fourth thing, upper vagina. That's malaria. Now here's what happens. When you take DES, you wind up getting stenosis of the fallopian tube. So when she gets older, reproductive age, she's going to have infertility. Big problem, infertility. Number 2, it messes up the uterus. Instead of a triangular cavity, it becomes compressed. It becomes a T-shaped uterine cavity. Well, when she gets older, good luck getting pregnant, infertility. Number 3, what's the cervix? Stenosis. Look, stenosis of the fallopian tube, stenosis of the uterine chamber, stenosis of the cervix. So when she gets older, infertility. So when a woman is exposed in utero to DES, 20 years later, when she tries to get pregnant, could have infertility. But on the exam, they're going to ask about the upper vagina. What happens here is they get basically metaplasia. They wind up getting glands. Glands, John, you're supposed to have squamous in the vagina. I know. They get this metaplasia. They get this glandular epithelium. We call this adenosis of the vagina. So let's repeat, vaginal adenosis. This seems to be the precursor. This is where the adenocarcinoma is going to come from. Because you're not supposed to have vagina, glands in your vagina. So over time, these are going to get irritated. So average age is about a 17-year-old. These will get irritated enough and they'll turn to glandular clear cell adenocarcinoma. So this seems to be the risk factor. So this is the precursor. After about 15, 20 years of exposure, of irritation, you're going to get clear cell carcinoma. Okay, makes sense? And it's all due to your mother taking DS in utero. Now, there hasn't been many cases of this because we stopped doing this in the 70s. So it only happens on USMLE exams because we don't use DS anymore, especially for it's teratogenic and it causes problems here. Now, I want you to remember this. Vaginal agenesis is malaria-type glandular epithelium in the upper vaginal mucosa. To identify it, what you're going to do is you're going to put a speculum in, and then you're going to put Lugol's iodine solution. Now, all the squamous cells have lots of glucose, so they're all going to stain. They're all going to stain except for the gland area. So in the upper vagina, you're going to see this area that stays red. It doesn't stain white. See, most of the vagina should turn white with Lugol's iodine. So it turns white. This one area is going to stay red and granular. That's the area you biopsy. If it doesn't stain, biopsy that red granular area, and you'll see glands or maybe glandular adenocarcinoma. Make sense? So again, very rare, but easy for the board to test. DS exposure in utero. All right, now look at this one. Again, very rare, but very testable. Embryonal, so small, round, blue, undifferentiated cells, small, round, blue cells, embryonal like an embryo. Rhabdomyosarcoma. Now remind me, my is muscle, so what's a myosarcoma? Malignant muscle tumor. What's rhabdo? Striated. Striated malignant muscle tumor. Now, an older name is sarcoma botryoides. I kind of like this name because botryoides means grapes. Grapes. What's coming out of this baby's vagina? Polypoid grape-like masses. Grapes coming out of the baby's vagina. But the key here is the age. They're always young. I'm talking infants, 1, 2, 3, 5 years max. So again, grapes come in the vagina of very young. Now later on we're going to talk about grapes coming out of the vagina of a reproductive age woman. That is going to be a tumor of a placenta. That's going to be a hydrogen mole. So moles also have grapes in the vagina, but they're reproductive age. That's a tumor of pregnancy. So we'll talk about moles and we'll get to a little bit later on in this chapter. But right here, this is the age, young. A 2-year-old with grapes coming out of the vagina, think immediately in blindneurotic rhabdomyosarcoma. It's probably coming from the muscle of the vagina. Now it can also come in the bladder too, and I also see this tumor in the head and neck sometimes too. So in blindneurotic rhabdomyosarcoma, head and neck, bladder, and vagina. But they really like it in the vagina because it's going to present as soft, gelatinous, grape-like masses that fill up and protrude out of the vaginal orifice. Now, when they come out, so here's the vaginal orifice, and they come out, it's these polypore structures under the microscope. Under the squamous lining, you'll see all the tumor cells growing in a layer. They all grow in a layer. These small, round, immature cells grow in a layer. We give it a fancy name. We call it a cambium layer. So that's very important. Grapes come in the vagina, under the microscope, under the squamous epithelium, you'll see these tumor cells are all growing in a layer. We call it a cambium layer. Now you're going to see these immature rhabdomyoblasts. They're kind of round or sometimes elongated. They become long. When they become long, look at the cytoplasm. Doesn't this look like a muscle cell? Got a lot of cells like a muscle. It's like an immature muscle cell. Here's another one. That's a rhabdomyoblast. Here's another one with the cytoplasm. Now look at this one. It's becoming elongated like a muscle should. So if it becomes elongated, sometimes they say, oh, it looks like a tadpole. Looks like a tadpole because it's getting elongated. So they call them tadpole cells. Or if they get really long, they become like a strap or a belt. They call it a strap cell. It's becoming like a muscle. That's what striated muscle is supposed to be. So look at these buzzwords. Elongated tadpole-like cells, strap like a belt or strap cells, and it's trying to be like muscle. Now, if you look really closely, not in this picture, but in real life, if you look under the microscope, you can often see cross striations. Makes sense because it's striated muscle. It should have cross striation. Now, how am I going to prove it's muscle? Well, it's got cross striation. It's got these rhabdomyoblasts, tadpole cells. Yeah, but we need a stain. A great stain for this is Desmond. Desmond is like actin. If you see actin, it's muscle. You see Desmond, it's muscle. Okay, so actin and Desmond, good markers for this. Desmond's the one we use because if I say actin, everybody knows actin's muscle. So like Desmond. Now another one you can use is MyoD1, but that's kind of easy. Myo stands for muscle. MyoD1 protein positive. How about myogenin positive? Myogenin, that's muscle. Again, pretty easy, muscle marker, definitely muscle marker. So they like to use Desmond. Desmond positive tumor cells, that's a muscle tumor. That's also vimentin positive. Vimentin is positive for all the mesenchymal tumors. But again, we need to know it's muscle. Vimentin's positive, that doesn't really help me. I need to know it's muscle. All right, now treatment for this. We're going to be aggressive here. We're going to do surgery, we're going to do chemo, do radiation. Now it's curable in about 2/3 of cases. So if we caught it early enough, we get aggressive, we can cure about 2/3. But again, it's a malignant tumor. Okay, now look at other buzzwords. Grapes coming out of the vagina. Botryoides means grapes. Number 2, under the microscope, the tumor cells are growing in a layer. This layer is called a cambium layer. Then you'll see these cells that look like muscle. The tadpole cells that are elongated like a tadpole, strap cells. They're positive for Desmond, MyoD1. They have cross striations. These are lots of clues to make sure you know it's a muscle tumor. Don't miss it. Febrile rhabdomyosarcoma, again, not very common, but easy to test. Grapes come to the vagina. All right, I think you guys got it. So let's do some vaginal recall, and then we'll take a break. Vaginal recall, let's see how good you are. What is associated with mothers who took DES during their pregnancy for threatened abortion? Well, number 1, you can get adenosis in the upper 1/3 of the vagina, and that can turn over many years to clear cell adenocarcinoma. Not many clear cells. We got Renal cell carcinoma is a clear cell. We're going to have seminoma and dysgerminomas. They're going to be clear cells. And then you got clear cell adenocarcinoma of the vagina from TS. So very important to remember this. So adenosis and clear cell, not very common, but TS exposure will increase the risk of getting them. Okay, what is it called? A cyst in the lateral vaginal wall? Well, we call them Gardner's duct cysts. It's a remnant of the Wolffian duct. All right, what do you call watery, copious, gray-green vaginal discharge, itchiness, and discomfort? Well, that sounds like vaginitis. This is Trichomonas vaginalis. It's tricky. You have a strawberry cervix when you look at it, little punctate hemorrhages, and you wind up also with a bug with this motility that's like a corkscrew. All right, now what about curdy white vaginal discharge? That's going to be yeast infection, candidiasis. All right, now what if you see red granular foci in the upper vagina that don't stain with Lugol's iodine solution? Okay, if it doesn't stain, that's the area of biopsy, and you're going to see adenosis. Yeah, adenosis, or it could be clear cell carcinoma. That's usually more of a mass, but it's not going to stain. It only stains, Lugol solution stains squamous cells. So all the squamous cells light up, everything that doesn't light up stays red granular, biopsy that. All right, what do you call great-like masses coming out of the vagina with desmond positive cells? Well, that's a muscle marker, so it must be embryonal rhabdomyosarcoma and sarcoma protrudens. All right, now metastasis from the upper two-thirds of the vagina, well, they're inside, so they're going to go to pelvic lymph nodes. Pelvic lymph nodes are iliac lymph nodes and obturator. That's what the pelvic lymph nodes are. And then, of course, if it's the lower or outer one-third, well, that's going to go more to the inguinal lymph nodes. It's deep or superficial. It's going to go inguinal nodes. Finally, men, how do you know if a woman really had an orgasm? I don't know. I was hoping you could help me. This is too much fun. Let's leave the vagina alone, and we're going to go into the cervix. So let's take a nice break. We'll come back and we'll do cervical cancer.